Welcome to all our participants this morning, and it certainly gives me great pleasure that as part of National Palliative Care Week here in Ireland, that we are hosting an event that really focuses on people with intellectual disability. And I'm so pleased to see people not only from all over Ireland, but from Canada, Chicago, different parts of the US, the UK, Spain, all over the world, and it really is tremendous to see you all, and you're all really welcome, and I hope you get a lot out of today. We're delighted at the Trinity Centre for Ageing and Intellectual Disability to be part of this event, and really to have these conversations around how do we support optimal end-of-life care for people with intellectual disability. I'm Professor of Ageing and Intellectual Disability at the Trinity Centre for Ageing and Intellectual Disability and at the School of Nursing and Midwifery at Trinity. We've been doing a lot of work in this area for many years. But we all know who work in the field of intellectual disability that person-centred care has become very synonymous with practice development and organisational culture change within intellectual disability services. And supporting people to live a life of their choosing is really much part of the fabric of good intellectual disability support and care. And these are terms you're all very familiar with. We know now that people with intellectual disability are living much more empowered lives, and this is to be really welcomed. Many are living, with great opportunities to work and education and living in the community. And people are living longer than they've ever lived before, similar to the rest of society. But what we also know is that people with intellectual disability will also die, similar to the rest of people in society. And while we have become somewhat more accustomed to engaging in conversations with people with ID about how they want to live their lives, having these same conversations with people with an intellectual disability and how they would like to die or what would be important to them towards the end of their life is often much more difficult for many of us. And this is often, of course, because we have concerns that we might actually upset the individual, and we don't want this to happen. And in the past, we are aware that we have often shielded people from death and dying, and that has poorly prepared people for their own demise or for their own deaths. But I think a lot of this has changed, and certainly from the data from the Intellectual Disability Supplement to the Irish Longitudinal Study in Ageing, IDS-TILDA, we do end-of-life interviews, and we are seeing that people with an intellectual disability now are engaged, and peers are engaged in planning and the funeral rituals and the Irish wake that we're all so accustomed to here in Ireland. So this certainly has changed. But what the data has also shown is that staff and family members often struggle with the how, the what, and the when of end-of-life conversations. How do I start this conversation? When do I start it? And what do I say? So in response to this, at TCAID and the IDS-TILDA team led by Professor Eilish Burke has developed a suite of easy read materials to address these difficulties and to support end-of-life conversations. And I'm going to introduce Eilish in a moment, who's going to give a very practical demonstration on these materials and how to use them. And Liz Hunt, who's also going to share in this presentation from the Brothers of Charity Service in Ireland, is going to share. Liz is a nurse, and she's going to talk about her experience in using them with people with an intellectual disability. And these materials are all free, and they're all available to download from our website, and June will pop that into the chat box. So without any further ado, I'm just going to introduce our keynote speaker for today, very good colleague of mine, Professor Eilish Burke. And Eilish is a Ussher Assistant Professor at the Trinity Centre for Ageing and Intellectual Disability in the School of Nursing at Trinity. And Eilish trained as a nurse in intellectual disability and also as a general nurse, and has vast clinical experience in working in the field. And she's also been involved with IDS-TILDA for many years and has developed an accessible MOOC really around how to do accessible health assessment and engage people in conversations and in health assessment. And I think her interest in end of life has also, and how to engage people in these conversations, has led really to the development of this suite of materials which Eilish has led out on and is going to present on. And co-presenting with Eilish today is Liz Hunt. Liz is an intellectual disability nurse and an area manager with Roscommon Brothers of Charity Service, and she has a huge experience over many years in working with people with intellectual disability. I will share her experience in practically using these tools. I'm just going to, without any further ado, hand over to Eilish to deliver the keynote. Thank you, Eilish.
Thanks very much, Mary. I'll just share the screen now. Come up. There we go. And I'll just move the little pictures out of the way. So thanks, Mary, for that lovely introduction, and hello to everyone. So my name is Eilish Burke, and I'm delighted to be here to share with you today this talk on supporting people with an intellectual disability at end of life, making the care conversation meaningful. I share this platform, as Mary said, with my colleague, Miss Liz Hunt from West Roscommon Services Brothers of Charity. I'm going to talk to you today about the development of the end-of-life planning tool and the usability of it. And the tool is called Glancing Back, Planning Forward. And Liz will enrich our conversation today with examples of how the tool was useful in practice, how it supported people to be prepared. Now, end-of-life planning is not so much a question of how do I want to die, but how do I want to live right up to the end? In Ireland, we do death very well. We do the rituals of death with great support for those left behind. However, having the conversation about dying with the person who is dying is often evaded. Perhaps not intentionally, as it's a very hard conversation. But if you think of it as an opportunity, so you shift the perspective from you to them, having this opportunity is a privilege, and being privileged with that opportunity to plan the care with the person is indeed really fortunate for you. However, not all people are given the opportunity, and some die without their wishes and dreams being known or met. So today, both Liz and I wish to provide you with key take-home messages to change that situation and hopefully help you to identify the opportunity. Support you to understand that end-of-life planning involves being prepared, good communication, good follow-through. It is an opportunity to record the wishes and dreams of an individual. So let's not avoid this aspect of care. Why deny yourself the opportunity? Because in the words of Margaret Wheatley, very great change starts with very small conversations held among people who care. Now, as Mary has almost contextualized it, so I'll quickly go through this. The past number of decades have seen a significant increase in the life expectancy of people with intellectual disability, and this is really wonderful success. It also brings with it the challenges such as the disparity which continues to exist. People have poor social networks, polypharmacy is highly evident, the increased incidence of loneliness, increased chronic and life-limiting conditions, and increased levels of multiple morbidity, which is highlighted by Mary in their paper on mortality, identifying the fact that despite individuals experiencing increased life expectancy, there is still a noted earlier mortality rate of nearly 20 years between those with intellectual disability and their peers in the general population. Now, this is important to remember because, like us, when we think about our loved ones, we want them to live forever, but of course, this is not possible. And for people with intellectual disability, it may come earlier than expected. That is why palliative care planning and considering that forward planning is important in the lives of individuals with intellectual disability. In essence, the palliative care needs of people with intellectual disability are the same as everyone else. You wouldn't want to die a death that is, wouldn't we all want it, that we're free of pain and any other symptoms, or spend time with our family, or be listened to and be involved in the choices and decisions that are made about our care and our treatment. And that's the essence of it. However, for people with intellectual disability, there can be some unique and challenging circumstances that can make it quite difficult at times to meet these needs. So these can include communication difficulties, which affect all aspects of palliative care provision, difficulties around insight and the ability to participate in decision making, or maybe unconventional ways of expressing signs and symptoms of ill health and distress, multiple complex morbidities, maybe complex family and social circumstances, higher levels of behaviour or psychiatric problems. There are a multitude of issues. So these are things we need to think about, and having a plan built over time will help with future circumstances that may perhaps unexpectedly arise. Now, the literature is replete with examples of where people with an intellectual disability's lack of preparedness and comprehensive approaches to end-of-life care meant that they may not have been able to be supported, or they may not have been as well supported to have a good quality of life in their declining years, or a good death at the end. Now, these challenging issues have been identified in the end-of-life study by Mary and her colleagues and myself as part of the IDS Tilda study. So in the study, the majority of respondents were paid staff carers who were committed to delivering high quality care based upon and benefiting from the relationship that had been developed with the person over years. Participants noted that dying at home surrounded by their family and familiar staff was the preferred model of care for the individual with intellectual disability. The themes emerging from the study included not joining the dots, whereby participants noted that not recognising signs of dying and uncertainty about conversations about death and planning for end-of-life care all led to poor experiences for the individual at end of life. The willingness of staff to support and care for the person until the end was clearly evident. And in the second theme to emerge, living the life desired in one's last days, there was a loving professional relationship portrayed in the accounts of care at the end of life. And carers expressed a sense of privilege in being able to provide that care. However, there were some who portrayed anxiety and worry and questioned what they did. Was it really what the person wanted? And finally, the third theme of dealing with death and beyond was summed up when carers talked about the lessons learned from their experiences, noting that the need for preparation, the need for good communication, and the need for good follow-through was seen as imperative. So considering these themes and the findings from the study, and the need that there was no specific planning tool for individuals with an intellectual disability available in an easy read and accessible manner, drove the development of the toolkit on the end-of-life planning. So glancing back, planning forward. The toolkit, it's really important because what it provides is a number of things for the person, their family and their carers. It supports carers to understand that end-of-life planning is not a once-off event. The toolkit aims to facilitate end-of-life conversations with the individual and enable the person have a sense of autonomy regarding their own death. So the development of the toolkit is important because having a plan in place supports the likelihood of less confusion and fear when end-of-life comes. Because after having or engaging in that care conversation about death and dying, there is a little bit more solace for the individual. The toolkit will support the fact that people with an intellectual disability have the right to know about death and provide opportunities to make informed decisions about their care. People with intellectual disability have expressed a desire for concrete, unambiguous information around death and dying. So that's really important to ensure that the information is concrete, unambiguous. And by having discussions about end of life, the person is helped to understand and cope with their illness. By involving the person in their end-of-life planning, it allows them to exercise control and autonomy about how they want to spend their last days. So glancing back, planning forward is the title of the toolkit, and it consists of 3 instruments or 3 different tools within one. So the carer's guide is the first part of the toolkit. And the second instrument in the toolkit is the how-to, which is an easy read guide of how to use the planning tool to support the individual understand the tool and the process. And then the final part of the toolkit is the planning tool itself. Again, it's designed in easy read, an easy read format. It supports the development of the plan. However, I'll keep saying this. This is a living document and as such must be revisited as often as is necessary for that individual. Planning end-of-life care is not a once-off event, nor is it a tick box exercise. And that's really important to remember. So let's have a look at the documents. So the first one is the carer's guide. And that's the first part. And that's your foundation for you as a carer, to guide you and support you in building your knowledge and understanding. And that's to ensure you are prepared to have the care conversation. It supports you to identify opportunities to start the conversation, and it provides you with hints and tips for engaging in the conversation about end of life. So through the instrument, there are opportunities for you to reflect on your own values, your own practice, and identify any gaps in your knowledge. So the tool provides you with a guide on the 4 elements of the care conversation and a guide on the dilemmas of to tell or not, which is also very much a challenge for individuals. Now, each section has a prompt, something like this, as you can see here in this slide. There's a reflect. So before and after a section within the tool, it prompts you to write down what you know on a specific aspect, then read the information and then reflect on your learning, which may in fact identify other aspects that you would like to know more about. So what it's doing, it's promoting your learning. The Carer's Guide, it's a resource to support your understanding of end-of-life planning and the importance of communication. So in general, when you think about disclosure about life-limiting conditions, it often involves a one-off consultation with a medical professional and yourself. However, for people with intellectual disability, conversations may be an ongoing process that involves a range of different people, from the family to the carers to healthcare professionals and so on. People with intellectual disability need to be given time to process information in small bite-sized chunks, one piece at a time, with the support of those who are familiar with their needs and their communication styles. That's really important. So to have that conversation, you need to build your knowledge and the individuals over time. Don't overwhelm the person with mountains of information. Small bits at a time, bite-sized chunks. Use concrete language. Relate to the person's background, their knowledge of the subject, and consider that the person's understanding of the future may be limited. So only provide information about what's happening now. And that perhaps is good at this particular situation or depending on the individual themselves. Also to be considered is the Capacity Act, and that allows for the assumption of capacity. And remember, capacity is a flexible concept. So the simpler and more reasonable adjustments you make to explain to the person, the greater the chance their capacity will be. Collaboration is key. So in the presence of the multidisciplinary, you take that multidisciplinary approach involving the family member, the carers, the individual themselves, and that's to ensure a very person-centered approach. But also that no one person holds all the information or has to take the sole responsibility. And that makes it much easier for all involved. And then finally, establish supports. What supports will be needed to be put in place for the person? Don't forget about their carers and their friends whom they live with. Often non-disclosure is considered. However, the person should be supported to understand any changes in their situation, protecting someone from upsetting news is not a reason to choose non-disclosure. You must consider, would disclosure be harmful? If not, ask if the person would want to know. If not, or if they would. And the decision is made at that point then whether to disclose or not. But it must be reassessed regularly. RNID Burke kindly allowed us to include in the Carer's Guide a flowchart she has developed to support decision-making when capacity has to be considered. And this is it here in this slide. Then when you consider those surprise questions from individuals, a very good acronym to keep in mind when you want to talk to an individual is the term affirm. So should the opportunity arise in an informal setting or sort of to informally engage in a conversation, you should again be prepared and consider this as an opportunity not to be wasted. So as I said, the good guide is affirm. So A for acknowledge. So acknowledge the person's concern or questions. Find out what the person knows about the condition. Immediate concerns are addressed by providing adequate information within the scope of your work. Don't promise unrealistically. I listened to a podcast recently from the Palliative Care team in the Learning Disability Network in the UK. And it was about individuals with intellectual disability dying. And one carer spoke about an individual being very frightened and kept asking her to promise she wasn't going to die. And this is a very difficult situation. It's very challenging. However, I thought the answer that the carer gave is one that I think meets the needs with kindness and gentleness. She didn't lie to the person or make up some story. She just said, I can promise you that you will live to the end of your life. And I thought that that was really lovely and it gave the person solace. So respond to any subsequent questions by providing accurate information within the scope, again, of the scope of your work, the scope of your practice. And always remember, as a carer, you're not alone. Meet with the multidisciplinary team, meet with the senior clinicians and the supporting team to discuss all concerns. There are distinct times when the care conversation will emerge. However, I would always say to be aware of all the opportunities. Some of the key triggers that point will include sort of the transition point in an individual's life. So if there's a transition or if there is a deterioration in their healthcare, so perhaps a healthcare event occurs or changes. Now these key trigger points will prompt the question of when will discussions on future end of life take place. So it could be at a time of a diagnosis or when the care plan is being reviewed. It could be at a point when the person has to transition to a more higher dependent care setting. Or, as I said, it could be those simple surprise questions when the person kind of initiates the conversation themselves. But mostly what you need to think about is planning in advance to ensure the individual can take part in that discussion. Again, I'll say it's not a one-time off discussion, but something that will evolve over time. Remember what I previously said, small bite-sized chunks of information over time. And then other triggers that would prompt the conversation are when the healthcare changes. So if the person deteriorates or the condition becomes more complex. Remember, provide concrete information and avoid the use of euphemisms. So engaging in care conversations is all about supporting the person towards a comfortable and good death, keeping their interest at heart and engaging them as much as they feel they want to. They will decide when they're ready to engage. These are really sensitive discussions, so be gentle and considerate. And remember, it's not a once-off single event. So that's the first part. So it really involves you as the carer and building your knowledge and having a good foundation and being aware and observing and watching out for the opportunities. So the second part of the toolkit is an easy read explanatory document that supports both the conversation and the understanding of what end-of-life planning is. So it provides the individual themselves and the carer with a 4-step process on completing the plan. So this includes step 1, think. So think about the things, for example, what comforts me? What upsets me? Who will I want to have with me? Where do I want to be? What are the things that make me feel at home? So if it is a case that I was transferred to somewhere else, can those things be identified and be brought to me to bring me more comfort and peace? Don't forget to write it down. What matters most is for this person. Step 2 is to talk about it. So talk about these things to someone you feel comfortable with, someone you trust. So talk about what would happen if you were to get very ill. Step 3 entails writing it down. It's important to record the person's preferences and wishes. You don't want a panic situation where things change suddenly and you're at a loss as to what to do. And then step 4 is review. This is really important as it's a living document. It needs to be revisited as often as the person requires. And then the final part of the tool is the planning tool itself, which correlates the information and provides you with prompt questions on what you want to do, what you don't want to do, what you want included. So you as a carer and you as an individual who's dying, who wants to use this particular document, you can collaborate and work together in completing this document. Remember, end-of-life planning, it's not the tick box exercise. It is not placing an emphasis on funerals, what flowers people want, do they want to be cremated or buried? Now, these are important questions, of course, and people with intellectual disability ought to be given the opportunity to identify these. But these are not end-of-life planning. That they're more of a when I die plan. What you want to focus on when you're considering your questions and when you're considering the information you're gathering is more of what happens before I die plan. So it is more what I want, what are my comforts. If I got very ill, would I want to go to hospital? What are the things that bring me comfort and peace? So they're the things we want to consider, want to think about, and want to document. Really important to document. It's important to have that end-of-life care plan because the preferences and wishes of the person will be documented. So it's worth identifying the opportunities to have that care conversation because you really have to ask yourself, on behalf of those for whom you care, at what point does their comfort become more important than the length of their survival? I think that's a quote from Irene Tuffrey-Wynne. So think about it. At what point does their comfort become more important than the length of their survival? It's very different for everyone, but you need to know what will make them more at peace when they are ill. And that's very important to know. So it's good to plan ahead. These are the references that I used in my presentation. I'd like to thank you all for listening. And I'd like now to hand over to Liz to talk about her experience and the practical application of the toolkit. And don't forget, as Mary said, the toolkit is available on the Trinity Centre for Ageing and ID webpage. So thanks very much, everybody.
I'm just going to introduce people to the other panel members because we do hope to have time for a panel discussion. And I'm really delighted to welcome Dr. Karen Ryan. Dr. Karen Ryan is a palliative care consultant. She's UCD professor, clinical professor and palliative consultant in palliative medicine at St. Francis Hospice and the Mater Hospital. And Karen was clinical lead for the national clinical programs in palliative care from 2010 to 2018. And I've worked very closely with Karen over many, many years. And I really do want to thank Karen for her immense interest in ensuring that people with an intellectual disability were included in all conversations around end of life, not only at the local level, but at the policy level, Karen. And I really do want to thank you for that. I think that has made and been of immense benefit. I'm going to also introduce Lynn Galligan. And Lynn is an intellectual disability nurse, and she's a clinical nurse specialist in dementia of the Daughters of Charity Disability Support System. And Liz has a master's in dementia and extensive experience in supporting people at end of life, or the Daughters of Charity service in responding to the needs of people who are aging, and particularly those with dementia, have really developed a state-of-the-art service for people at end-stage dementia, with a 6-bedded home for people who are advanced or terminal dementia. Liz was the nurse manager there in that unit for many years and has extensive experience in supporting people at end of life, and also providing outreach to our community homes who are also, and family homes who are also supporting people at end of life. So I'm really glad that Lynn is here to share that experiences. We have a number of questions that has come in. I think, Eilish, you have talked a lot about people being confident in engaging in that end-of-life conversation, and when should we start that conversation? I think you've covered that adequately. Do you want to sum that up in any way for our participants?
Yeah, that's, I think being confident is having the knowledge and building your knowledge. So that's the foundation. And I think if you're supporting somebody and who's maybe got a diagnosis or whatever, building enough information around that so that you have the information to answer questions is really important. So that to me is your foundational block. But also, identifying, it mightn't necessarily be at that point. It could be earlier. I think there's no actual one specific point to start a conversation like this. It's identifying opportunities and looking across the lifespan. Now I see Liz has got herself up and working, so
yeah, so
I'll stop
over Liz to you. And apologies, Liz, I know how terrifying that is when you're on a call like this, but well done. And I'm going to hand over now to you, Liz. So just, take it on. Yeah, great.
Thank you so much, Mary, Professor McCarron, and thank you, Eilish, for your previous presentation. It was very interesting. I'm so sorry about that. As Mary said, and as Eilish said, we had a practice run earlier and everything went smooth, but the screen just completely blocked on me there. So look, we're here now and we'll get going. So just without further ado, I will continue with my presentation. So as Mary said, my name is Liz Hunt and I'm registered nurse with intellectual disability for many years. I am currently working as area manager in the Brothers of Charity Services in Roscommon. So I'm delighted to be here today to share our positive experience of using the Glancing Back Planning Forward tool. Just give a quick background on the Brothers of Charity Services. The Brothers of Charity Services is accredited with the Council of Quality and Leadership, and this is an international accreditation. We continuously strive to improve the quality of life and the quality of service for all the people who avail of the services. So as Eilish would have said earlier, and also Mary, all our services operate from a person-centred, rights-based approach, empowering people to make decisions in their day-to-day lives, while also supporting people with the bigger life decisions. And we've seen that already throughout the presentation about supporting people with bigger life decisions that people may have to make towards the end of life. So I suppose for our international audience that are joining us there today, County Roscommon is it's a rural county west of the Shannon. And in 2008, the Institute of Public Health in Ireland found that people in County Roscommon had the highest life expectancy of any county in Ireland. Actually, that was news to me. I wasn't aware of that. So it must be good air down here in the west of Ireland. So all of our services are integrated and supported in their local community. Now, I manage the services in the west of the county, and they're located in towns around the county of Roscommon, from Ballinlough, Castlereagh, Loughlin and Ballintubber. So again, an overview of the services that I manage at the moment is we have 58 adults supported in the West Roscommon Services. 50% of adults are over the age of 55 years of age, and 10% of those adults are over the age of 65. So that's, and then of those 53% of adults, they're living in homes provided either by a local housing association or by the Brothers of Charity Services. And 35% of adults live with family members. And we support 12% of adults to live independently. Now again, as people are aging and they're living longer, a number of older people supported are living with chronic health conditions, and that would include dementia. So the service had to evolve on from a social care model to include nursing to support people with aging and more complex needs. And just to give you an overview of those services, they are provided in 2 small community homes here in the West Roscommon Services. And as I outlined earlier, we come from a rights-based approach, and the key themes here that I have mentioned are capacity, which Eilish would have addressed already, rights, empowerment, and engagement. So as stated in the Assisted Decision-Making Act, we always assume capacity. We continue to empower people by providing accessible information to enable them to make informed decisions. Our motto is, nothing about me without me. And as part of the supports for the ageing population, this included the end-of-life planning and supports. So now I've given you a broad overview of the services. Now we will look at how we included the end-of-life planning tool into practice. We found the tool a great resource to support the end-of-life conversations. Throughout people's life, they are supported to live their lives, and the natural progression should be to plan to end their life, to plan how they will end their life and how they would like to do this. So I'll go into more detail on how it supports the person and with their families. So the pace, as Eilish would have already said, the pace of the conversation was dictated by the person. We found that the tool anchored the staff and instilled confidence around the end-of-life discussions. Prior to this, staff reported that it found it difficult to introduce conversations around end-of-life with both the person and their families. The tool also provided the guidance to prompt questions and stay on track to ensure that all areas were covered. We found early planning was key, especially when there was a diagnosis of dementia, as it ensured that the person could actively engage in their end-of-life planning. The relationship with the staff is key. In people's homes here in the Brothers of Charity Services, people are supported by staff who have worked with them for a long time. They would have built up a strong bond and trusting relationship with them, and this enabled and supported natural conversations. Staff availed of opportunities like hearing of a friend who was sick or maybe a friend who was in hospital, and this would prompt questions around recovery or maybe end of life. Or also opportunities like maybe marking the anniversary of a friend or a family member, or even a lot of them are all watching soaps on television, and maybe there was a death or a person sick on the television. These all created natural opportunities to introduce conversations and forward plan. Sorry, now I'm frozen here. And again, I would have spoken to staff themselves of how they introduced these conversations. And one staff reported that, and you can just picture the scene, they were sitting in the sitting room together, and the staff member just started talking about her own family member that was ill and going to hospital. And she was gathering the information as how the person themselves was receiving this. person that she was with. And she continued on the conversation. And again, knowing the person, she watched for the reaction of that person or how they were receiving the information. And she said, actually, that was the best opening point she had. During that conversation, she gathered vital information of how the person themselves would like their lives to go as they aged. So again, as I said, over the time, staff availed of similar opportunities to support people around at their end of life. They would talk about if the person got sick, what they would like to do. They were showing them options of, when they'd be in hospital. Now, obviously, they did inform the person that, if the person chose that they might like to stay at home when they got sick, there may be a time when they had to go to the hospital. And again, they give people accessible information to understand that. If the person was talking about what they had, their possessions, they were supported to meet with the solicitor. They were given the information about through the legal route they would have to go to make their will. Things that they would like to do was also documented, like places they would like to visit, family members that they might have been estranged from, how they would like to meet up with them. So the supportive conversations then continued to include on when the person would pass away. And those conversations, again, prompted by experiences that they had, like being at a funeral and what church they would like, the priest, maybe their readings, the funeral directors, all this would have been discussed with the person. So as snippets of information was gathered, the end-of-life document was populated. As Eilish has said, it was a living document. It was a document that was taken out and populated as information was received. And it wasn't this like sit down and have a talk now about end of life. This information was gathered up all over time. And this information then was shared with the person, their family, and others as the need arose. So the need to share this personal information was discussed with the person. One person actually chose to personalize her own plan with lots of photos and pictures, again, giving them ownership over it. And staff continued to use the tool as a reference point, revisiting with the person and assuring the person of a commitment to follow through on their wishes. So while all the information was being gathered, it wasn't just the staff and the management team. It required the support of the wider team, hence the importance of this collaboration and partnership, ensuring the person was at the centre. The psychology team recognised and supported the early intervention of the wider team, and support was also provided from the physiotherapy department, social work, occupational therapy, speech and language departments as required. Involving the family as part of the natural support network from the beginning was important, as they contributed important information throughout the process. The document gave great reassurance to the family, knowing that their loved ones' wishes were documented, and it took the added responsibility from them. This enabled them to spend quality time with the person towards the end, maybe reading their favourite poem, listening to their favourite music, or just sitting with them and keeping them company. So moving on to palliative care. And the early engagement with palliative care was vital. Again, this enabled them to become familiar with the service that we're providing. And it also gave them an opportunity to build rapport and to get to know the person themselves, to get to know the person they were supporting, to get to know their personality, while also getting to know the staff team. Initially in a supportive role, and then later on in hands-on comfort care. They also met with the person's friends and family and offered them comfort and support. Another important team in this partnership was the medical and the GP consultant team. So we ensured open communication with all medical personnel, again, sharing the wishes of the person. and their support network as above. The medical team were assured and confident that everybody was working together to provide holistic end of care for the person. Example, when the person was unable to travel to see their GP, the GP was happy enough to engage with the wider team via phone contact. I've also included here the funeral directors, because the relevant parts in this document was shared with them also, and they themselves found it a great support. They commented on the attention to detail that the document held, stating that everybody should have one, and it made their job so much easier, and there was no ambiguity. So now we had the clearly documented roadmap, and we also had the commitment to follow through on the person's wishes. So from our example, the person was able to remain in their home, surrounded by their friends and family and the people who knew them best, because this is what they wanted. The person could hear their familiar voices. They could listen to their favorite music, again, which they had documented. And they experienced the familiar touches and smells that they were used to. Their friends and families had opportunity to spend some quiet time with the person. And I would actually say that the grieving process had begun, as people had witnessed the decline and the loss of the person they knew. And this again was normalizing the dying process. The person themselves would have liked to have all their friends there, but due to the COVID pandemic, this was not possible. Instead, let's move on here. Instead, their friends and family formed a guard of honour as the person went on their final journey, and they held sentimental mementos like photographs, maybe the person's favourite flower, and they wore colours that they knew the person liked. The person's detailed wishes were followed through on. They had very details about the prayers they would like, people who they wish to say their prayers. They had chosen their readings. In consultation with their family, they had decided on their church. They had spoken with the priest. They had asked close friends and family members to bring gifts forward. They'd chosen their music. They'd chosen the singer they would like in their church. And the funeral directors supported all of this. So that was our experience of using the tool. And then just speaking with the staff and the people who were closely involved in this, this is some of the perspectives that they shared. So one friend said, and again, I'm just using an anonymous name here, "I thought of Mary as I carried her favourite CD to the altar. I know she loved that CD." And a staff member reported that this was a beautiful experience. We sang one of her favourite songs and lit a candle as Mary left the house for her last and final journey. Another staff member said, "This was her home. It was great she could remain in it. She didn't want to be anywhere else." And a family member said, "You were her family. This was her home." Another quote there from both family and staff. "She always loved talking about the angels. We ensured angels was very much part of her final days." So to end my presentation, I leave you with the words of Cecily Saunders. "You matter because you are you. You matter to the end of your life. We will do all we can, not only to help you to die peacefully, but also to live until you die." So I suppose my final summing up is, dying and death is a natural progression that comes to all of us. It's never too early to start the conversations. So seek out those natural opportunities and engage in those normal conversations. Use the tool as your guide and make sure to document and share all the information that you've gathered. And again, another key message for all of us was early engagement with the wider support network to ensure the wishes of the person can be followed through on. So thank you very much. I will now hand you back to Mary, and thank you for listening. And I will be joining the panel afterwards for any questions that you may have. So thank you.
Thank you so much, Liz. That is wonderful. Great presentation, and thank you for sharing your experience in using the suite of EasyRoute tools. I am concerned about the time, and we have a lot of questions that have come in, but hopefully many of them have been answered as throughout those presentations. But I'm quickly going to move on to Karen, Dr. Karen Ryan. Karen, what would you please advise why a 61-year-old man with Down syndrome with end-stage Alzheimer's disease, why there is no DNR written up for him?
Thank you, Mary. A good question, and unfortunately, I suppose an all too common experience, not only for people with intellectual disability. I think it is important to recognise that it is quite a common experience also in the general population, that there can be a reluctance to put DNAR orders in place, even in the advanced stages of illness. I suppose the reasons are many. Some of the most common ones can be, I suppose, a great sense of attachment or love for the person, and a feeling that it is too difficult to project forward and think about this stage of illness. And therefore, sometimes if one doesn't talk about it, then perhaps one hopes that it isn't going to happen. Another reason can be that actually there isn't a good understanding of the natural history of a person's illness, and there isn't a clear understanding of potentially what options might or might not be available to them. And there hasn't been a careful consideration of the pros and the cons of what might be offered. And then I suppose one that has been very much to the forefront of people's minds with the pandemic has been the idea that perhaps, goodness, if there's a DNR order in place, does that mean that actually I won't get other forms of care, whether that be more simple care like antibiotics or other kinds of care? And of course, that is actually a misperception or a myth. DNAR orders should only relate to the resuscitation event, and it is entirely possible for people to get other forms of interventional care appropriate to their condition, even if a DNAR order is in place. So a multitude of reasons. What I might suggest, though, in terms of perhaps an action, based answer in terms of what might be the way forward from this, I think the first step Eilish has alluded to, and that's the first piece about gathering information. So I would try and understand the facts of the person's illness. What is the medical perspective on where the person is in their trajectory of illness? What is the nursing? What are the other members of the multidisciplinary team's perspective? Very importantly, I try and understand the person's perspective themselves, whether they have an understanding or whether they have any wishes, values, or preferences. And then, of course, the other important people, the family and the person's life. And then once we've gathered all of that information, we're then at the stage of bringing people together to try and start that next stage of communication, which essentially is listening to those perspectives and trying and brokering or finding a way forward that, really is tailored to the individual needs of the person. Thank you.
Great, Karen. Thank you so much for that very comprehensive answer, and hopefully that's helpful. Can I ask you a further question, Karen? What do I do when my loved one doesn't want to hear about it? They don't want anything formal, and I haven't pushed.
Oh gosh, that's a powerful statement, and thank you for the person who has put that in, because it's obviously a deeply personal experience. I'm not sure whether the person is actually a person with intellectual disability who's facing an illness or something in the future, or whether they are a carer or family member. I think if it is a person with an illness themselves, what I would say that perhaps, are there other significant people within your network, that aren't perhaps those immediate loved members that are finding it hard to talk about? And see, if there's somebody, a trusted friend, a member of the team involved in your care, that you might be able to share these feelings with, and that would act as an advocate and a support to then bringing these things forward towards the family. And often, this important person can be anyone. It could be a key worker, it could be a social worker, a psychologist, but first maybe try and reach out. If it is a carer and they're thinking ahead, again, this is a very natural thing. People cope in different ways. Some people, really have that piece that they can't look ahead. Other people feel it's the right thing to do. So what I would say is perhaps, maybe this recording might be something that might be played, into the future. It might be a useful resource. Again, perhaps reach out to what other supports are available in the network, whether there are other members of the caring team that might be able to help and support you through this journey, or other maybe advocacy or supports. And perhaps I'm sure the other members of the panel and myself, Mary, may be able to point towards some of those services that are there in a listening and advocacy way.
Yeah, it is all about trying to help the person to be prepared and engaging this in multiple ways and eliciting other people from the service or area or larger network that may be helpful. Thank you very much, Karen. Lynn, I just really wanted to have a question for you. One of the big challenges very often within ID services is that people often have difficulty in recognizing actually when somebody is dying. And a question has come in, how can we improve timely recognition that the person is actually dying? Based on your experience, and you've supported many people who are dying.
Thanks, Mary. I suppose the main thing is that prompt recognition of, and that somebody is actually actively dying. And there is a table, a small table, and it's a table on the signs that active end of life is approaching. And I suppose it's the presence of any three of the following symptoms, which does indicate the final days. So it's experiencing rapid day-to-day and irreversible deterioration, completely being bedbound or requiring frequent interventions, becoming less conscious than the normal baseline with lapses in and out of unconsciousness, or a diminished, I suppose, response to voice stimuli, being unable to swallow anymore, a diminished or a lack of urine output completely, an acute event that requires a revision of their current care goals, profound weakness, changing breathing pattern, the presence of increased secretions in the chest or gurgling or that kind of rattling sound, changes to body temperature, be it kind of hot and clammy, or the presence of cold, clammy skin as well. And then that kind of, I suppose, it's like a pale or a mottled skin effect as well on the person. And I suppose knowing those symptoms and, the combination of possibly three, or in some cases three or more of those symptoms, is a real kind of indicator to the nurse providing end of life care that things are happening, are going to happen now in the next while.
Yeah, thank you, Lynn. And I know somebody has put in, where can we get that? I mean, I've just written a book chapter for a book which will be coming out shortly, and I will give people information on that, and I've documented some of those items, included a table there to assist people. So I will let people know when that book is coming out. That's excellent. Thank you so much, Lynn. How can we recognize pain, Lynn?
Yeah, so I suppose within the area of intellectual disability, it's very important to know the person, first of all, and to acquire a baseline of that person as well. There's no point in trying to assess pain if you don't actually know what the baseline for that person is. So using established pain scales is something that we would do. We would definitely use the DISTAT pain assessment scale. The DISTAT allows for a baseline of pain and then to measure against how the person is presenting now to see if they are in pain or not. And I suppose it looks at more kind of things than just the physical aspect of things. It would look at, if somebody is vocalizing more, if there's the presence of behavior as well that mightn't have been there before. So that's how we would diagnose and recognize pain. And I suppose it's important just to know as well that in the area of intellectual disability and end-of-life care, that it's not necessarily just the pharmacological inputs and into end-of-life care, that there is very much the non-pharmacological input to relieve pain as well for people at this stage in their life as well.
Yeah, and I suppose it's really important to recognise that there are many types of pain at end of life. It's not just physical pain, there's spiritual pain, psychological pain, emotional pain, and it's to be able to recognise all of those various types of distress that somebody may have. A question has come in here as well from Sri Lanka. medication is rarely given to people with learning disability in our country, and does this mean that memory loss will be more severe as they get older? Well, I mean, I assume that this person is talking about the anti-dementia agents like the Aricept and the memantamine, which are commonly used in Ireland. I mean, they have been trialled in people with an intellectual disability. And what we can say is that they're safe, but we have very few really large-scale trials of these medications in people with ID, but we are using them. But what we do want to say is that, you know, from the general population, they have some effect, but probably not the level of effect that we might have hoped from. But certainly they do appear to extend people's function for a longer period, perhaps for another year or so. So there is, certainly we are seeing some effect. It's more documented within the general population. But I think the important thing for people with intellectual disability or learning disability is that we're actually diagnosing dementia in time, because many of these medications are only effective if we're picking up dementia in the early stages. So that's why in Ireland we've set up a new national memory clinic for people with intellectual disability to try and improve diagnostic accuracy and the timing of diagnosis. And this is really important, not only with respect to medication, but also with respect to the end of life discussions that we have just had. And another question was, what's the best setting for somebody with advanced dementia to live in? And I think for anybody with advanced dementia, the best setting is the home of their choice, in the community of their choice, surrounded by family and friends. So we need to structure our services that we are able to bring that outreach support to there. But sometimes it may happen that despite your best efforts, somebody isn't able to give care with comfort or with safety in that setting. And then you need to really decide where you're going to move that individual to. We know that within the intellectual disability settings, some ID services set up their own areas that people can be supported. And I know certainly has been, I think, a lot of issues around the re-institutionalization of people with intellectual disability at the end of their life to the nursing home model, which is more of a large congregated setting. And I think that post-COVID in this country and in every other country, we're going to be looking at that model of care going forward and hopefully developing that forward. So I would say it is very possible to support people. Once you have good support, you will need nursing support. You need to identify what is the ceiling of care with your current resources and how can you get what's required there. I think we are out of time, unfortunately. I think we had a very good presentation from Eilish, and I really do want to thank Eilish for such a really powerful overview of the end-of-life planning tools, and for Liz then for her practical discussion on how they have went. Eilish, did you want to ask a question there?
Yeah, Mary, just to quickly say there are a few more questions there that I can see coming in that I will address. One from Victoria, one from Humera, and one from Chris that I can address again, seeing as we've run out of time.
Yeah, we will endeavour to get back to people. Thank you, Eilish, for that, with some additional questions that we didn't get through. But I just want to thank our speakers, both Eilish and Liz, and our panel members, Karen and Len, for being here today. I also want to thank the All-Ireland Institute of Hospice and Palliative Care, Kathy Payne, and I particularly want to thank my own team at Trinity, Gavin Dan and June O'Reilly, for the incredible support that they have given in getting this together. And I'm going to hand back over to Kathy.